We're going to get going. So just wanted to welcome everybody to our third webinar for Concussion Week. I'm going to, you can see on the screen the land acknowledgement. Given that it's Orange Shirt Day tomorrow, and in general, it's very important that we take some time, read through, and acknowledge the lands that we are on today. I'm going to give everyone a moment to take a look at that and internalize it. Okay, so my name is Sarah Rabinovich, and I am the chair of the OATA Board of Directors. Athletic Therapy Ontario is proud and pleased this evening to be presenting our third really great Concussion Week e-learning offering to our members. As we all know, we athletic therapists are the frontline concussion care people who need to stay alert. We need to stay alert to the changes and updates happening in concussion management in order to present, to work within the best evidence-based guidelines. On Saturday, the OATA was so happy to participate as a sponsor partner with Heads Up Can at a half-day seminar featuring the latest information on ocular concussions and the role of vision assessment in concussion treatment, particularly for long-haul concussion patients. So that was really wonderful. On Monday, we had a great Lunch and Learn webinar with UHN Kite Research Networks that included Living Concussion Guidelines Project and the Neuro Pathways Project. Both the new guidelines and the resources from both projects are available on the member portal. This evening, it is my pleasure to welcome Sport and Exercise Medicine Dr. Alex Francella to take us through through a thorough assessment of the changes from the SCAT5 to the SCAT6 to have us benefit from his views on the rationale behind these changes. Following the presentation, we will have a question and answer opportunity. Dr. Francella, we look forward to your presentation. The floor is yours.
Awesome. Thank you so much, Sarah. So yeah, as Sarah's mentioned, my name is Dr. Alex Francella, and today we're going to be talking about the changes between the SCAT5 and the SCAT6 and the rationale behind those. So again, thank you for inviting me. Thank you for Gus for the opportunity and the idea behind everything. So just to give you a brief background about myself, my main clinical responsibilities are as a sport and exercise medicine physician at the University of Toronto, David McIntosh Clinic, and at Cleveland Clinic, Canada. I'm also the lead sports medicine physician at Seneca College, where I take care of their varsity athletes alongside Steve Kopas. My main team coverage at the moment is with Canada Soccer and the senior men's national soccer team. Below there is a photo of me at this past summer's Gold Cup. I've also provided some care with their under 20 and under 23 teams. In the past 2 seasons, I was the team physician with the Toronto Six, which is a professional women's hockey team, or was, I should say. Unfortunately, with the formation of the PWHL, the franchise is no longer in existence. Some of my educational roles are as an editor at a free open access medical education website called sportmedschool.com. And some of my other event coverage in the past and team physician coverage has been with the Toronto Wolfpack, as well as with Canada Basketball. So just to say, I do not have any financial disclosures in relation to this topic. Okay, so in June 2023, the 6th International Conference on Concussion in Sport was held in Amsterdam with the publication of the Concussion in Sport Consensus Statement. This was a much anticipated document, as the one prior to that was in 2016 in Berlin. And each subsequent ones prior to this were released about every 4 years. So obviously 7 years was quite a long time with the pandemic definitely affecting that. We won't go through the entire consensus statement at this time. However, I do encourage you all to take the opportunity to read through it. And we'll go through a few key findings just to highlight it. So firstly, the definition of a sport-related concussion was updated, and they define it as a traumatic brain injury caused by a direct blow to the head, neck, or body, resulting in impulsive force being transmitted to the brain that occurs in a sport and exercise-related activity. This then initiates a neurotransmitter and metabolic cascade with possible axonal injury, blood flow change, and inflammation affecting the brain. The signs and symptoms, as we know, may present either immediately or evolve over minutes and hours, and are commonly resolved within a day, but I think days is calling it a little soon. Most of them can be prolonged. They have updated the return to learn and return to sport strategies. Specifically, there have been changes on how an individual can progress through the stages. So I won't go through that today, but definitely take a look, as that is a bit of a practice changer as well. They outline the strong evidence behind physical activity and aerobic exercise in the early treatment of concussions. They continue to define persistent symptoms as greater than 4 weeks and identifying that those individuals require a multimodal clinical assessment. So as it sounds like you guys did a bit of a workshop earlier in the week on the importance of cervical and vestibular rehab. So they are recommending this in athletes with neck pain, headaches, dizziness, and balance problems. Long awaited, as they finally have recognized some of the long-term effects of sport-related concussions and repetitive head impacts with specific notification of a CTE. They also mention the roles of advanced neuroimaging, fluid-based biomarkers, genetic testing, and other emerging technologies. So while they do recognize that these are valuable research tools, they're not yet really set for prime time or routine clinical practice. So we'll see how that evolves over the coming years. And finally, they've updated the CRT6, the SCAT6, and they've added the SCOT6, which we'll talk about, and then the child in SCAT6 and SCOT6. Okay. So the CRT6, or the concussion recognition tool, is for non-medically trained individuals to identify and provide immediate management of suspected concussions. They do highlight that this is, again, not a diagnostic tool. Personally, I think that this is a valuable tool and should be provided, I think, at all amateur levels to coaches, at the very least, again, referees potentially, because I think a lot of these environments in these amateur sport leagues, especially with young children, may not have healthcare professionals present at them. So it would be helpful and in the interest of the well-being of the athletes to have those individuals trained or at least aware of the CRT6. So as the literature has evolved over the last 7 years, we've realized that the limitations of the SCAT tend to decrease, or the utility of the SCAT, tend to decrease after about 3 to 5 days post-injury. And so therefore the SCOT, or the Sport Concussion Office Assessment Tool, was developed to help provide a more thorough assessment in the office setting. Again, not going to go through that today, but we're going to move forward and look at the SCAT. So over the last 7 years, the SCAT5 has really been the gold standard for sideline concussion assessment. But as time goes on, there's always a new challenger that can emerge. And so, like another great battle that I've seen in the past, it's only a matter of time before that young challenger comes along and takes down the reigning champion. So just like this great race that we all remember back in on the silver screen, we're going to have a little bit of a tail of the tape right now and compare the SCAT5 to the SCAT6. So looking at the first page here, the first thing that jumps out to me when we compare it is that the patient details have been removed from the first page. Now, the next thing that I notice when we go through it is that the term healthcare professional is used, whereas in the SCAT5 previously, they said physicians and licensed healthcare professional. I think that the use of the term healthcare professionals is much more overarching and an inclusive term, which more accurately represents the variety of individuals who are trained to administer the SCAT. The next thing that we'll see is that the time limit needed to perform the SCAT has been increased from less than 10 minutes to 10 to 15 minutes. The rationale behind this was to put pressure on the variety of sporting governing bodies and leagues to implement rules to accommodate the proper use of the tool in the interest of player welfare. Moving down through the left side of the column there, they do say that the verbal instructions are now written in blue italics and not just in italics. So this may seem very small, but as we move through it, you'll see that visually when administering things, it makes a big difference. Moving over to the right side of the page under the key points section, I'll bring your attention to the second bullet point, which states that no athlete diagnosed with concussion should return to play on the day of injury. Now, this isn't new. However, in the SCAT5, it's embedded at the end of the first bullet point. So I think just making it its own separate thing really highlights the importance of that statement and for it not to be missed. Moving down, they also now recommend that the athlete should not be taking medications such as aspirin or other anti-inflammatories, sedatives, or opioids. Interestingly, there is not any mention of acetaminophen or Tylenol, for what it's worth. Next, you can see that they say that in the SCAT5 that it's important to consider repeat evaluation in the assessment of concussions, whereas in the SCAT6, they highlight the importance of continuing to monitor the athlete for ongoing worsening or the development of additional concussion-related symptoms. And so we'll continue now to the second page of the SCAT6. So you can go to the next slide there. Wonderful. So on this page, we now have a centralized portion for all the patient demographics, including their concussion history. And so that's new and I think a welcomed addition. Another new addition is this flow chart that can help with the on-field assessment and your decision making and where you're going to take decision points to either remove the player from play for a suspected concussion and when you're going to transport them potentially to hospital or medical center if needed. So moving then to the immediate or on-field assessment. My initial thoughts when I look at this page is that it's just much cleaner. Every step has its own box. The colors sort of pop out at you, and it's just a lot easier to look at. So now we're going to go through each step one at a time and compare and contrast. So firstly, when we look at the observable signs, there has been an addition of 3 new ones. This includes falling unprotected to the surface, impact seizures, and high-risk mechanism of injury. Next, you can see in step 2, which is now the Glasgow Coma scale, whereas previously it was step 4. Again, they don't give a rationale behind it, but that's just kind of how it is. Then on step 3, the cervical assessment, one change that they've made here, which personally I really like, is they've changed the wording of that first question, where before they asked, does the athlete report that their neck pain is pain-free at rest? It's just a lot of words that I think is really hard to sort of understand when you're in the heat of the moment. Now it's simply, does the athlete report neck pain at rest, period? Yes or no? Very simple, very easy to understand. They've now added on a question about tenderness to palpation, and the remainder of the other ones remain the same. Something that they've now added is step 4. So this is the coordination and ocular motor screen. Previously was not on the on-field assessment, as you can see. I think this highlights the importance of identifying these ocular motor symptoms early on, and that can help us catch more concussions than we were previously. Step 5 is now the MATIC questions, which we're all very familiar with. Previously, it was step 5, very early on in the on-field assessment. The rationale behind this is that they want you to rule out identifiable objective signs of concussion before moving into a cognitive screen. So if one of these, one of those step 1 through 4 are positive, that's probably enough to remove them from the on-field assessment and into the off-field assessment. However, if those are normal, then you want to start looking at any potential cognitive deficits that may be present. And if those are positive, it's going to prompt you that you're going to need to remove that athlete from the field of play. So now we've moved to the off-field assessment. Looking at the SCAT5 on the left-hand side of the page, that athlete background has been removed, but they've kept the athlete background on the risk factors that would potentially lead to more prolonged concussion recovery in step 1 in the SCAT6. When we move towards a symptom evaluation, this is our first real example of where that blue italics kind of makes a bit of a difference. It really sort of pops off the page, makes it easier for you to read, and just helps with the general flow of this part of the assessment. There's very clear delineation of when you're going to hand the form to the athlete and then when they're going to hand the form back to you. Then the tallying of the total number of symptoms and the symptom severity score is done after you've received everything back. Whereas before, if you can see on the left-hand side, they didn't hand it back until the end. Okay. So now moving on to the step 3, or the standardized assessment of concussion. I think a page that we are all very familiar with the SCAT5. Personally, I always found this page very busy, especially with that months in reverse order tucked away in the corner. And when you're in the heat of battle and you're trying to do a SCAT as fast as you can, I know personally I've missed that a few times. I'm not ashamed to say it, but I think they've made, again, some changes here that helps to counteract that. So we'll go through each one of these sections a little bit at a time and compare and contrast. So moving forward, we're going to look at the cognitive screening. So the orientation questions remain the same. The immediate memory, this is probably the biggest change, where there is a removal of the 5-word list, and with there only being the 10-word list present. Now, they've done this because over time they noticed that a ceiling effect was apparent in terms of learning and other concentration subtests. So they wanted to make it more challenging with the 10-word list. One of the other big changes here is that they've now put the words in a vertical orientation instead of a horizontal one, and provided you with a scoring system of 0 to 1, just making it, again, much easier to track the answers and follow what the athlete is saying. My main critique here with the 10-word list is that they don't describe what an acceptable number of correct words is. I think this is going to vary on a case-by-case basis. And so the practical administration of this, while I understand why it's challenging, they want to make it more challenging, it could be hard. And so one of the things that could counteract this potentially is the use of baseline testing. Now, I'm not advocating for baseline testing. The literature does not support baseline testing. I'm just saying that with the switch to the 10-word list, we need to know kind of what an acceptable number of correct answers is going to be to help us with our decision making. So moving on to the next part, looking at the digits backwards. This hasn't changed. It seems about the same. Interestingly, when you read the document, they mention something about adding digits and that they've increased the longest string by 2 digits, again, to try to reduce a ceiling effect. However, when you look at the actual document, the final one is still 6 digits, just as it was previously. So I don't know if I'm missing something, but I can't find anywhere where they've added that 2 additional digits to it. Looking at the months in the reverse order, not so much tucked away as it used to be, but some important changes here, whereas now the athlete has to answer as quickly and as accurately as possible. And in order to score a point, they have to have no errors and complete it in under 30 seconds. The rationale behind this, again, is to make it a little bit more challenging. They don't provide why they arbitrarily picked 30 seconds, but that's just the way that they decided to say that that was the cutoff. So now continuing to move forward, this is the last page of the SCAT5. So the document itself is much shorter compared to the SCAT6. SCAT6, I think, is about 9 pages long. So you can see the neurological screen that was previously present is no longer there. And then we're going to go through each part of the remaining sections one at a time and contrast them. So we'll move to the next one there. So looking at the balance examination, the modified balance error scoring system, or the MBES, very similar to what it was in the SCAT5. My only critique here is that in the actual document, the top form is at the bottom of one page, and then the bottom square is at the top of another page. So just kind of the flow can be a little off at times. Moving to the next page. Again, your scoring system for the modified best, they've added this optional to perform it on foam. If you find that the modified best is normal, then you're supposed to move to a timed tandem gait. And they instruct you to place a 3-meter long line on the floor or firm surface with athletic tape, and then you can time how fast they can walk back and forth on that tape for for a time thing. You're going to do it 3 different times. Now, I think this is a really important practical question to have here, especially with athletic therapists, as you may want to consider: should we be placing a 3-meter long tape in our treatment rooms or some sort of marker, so we're not scrambling at the last moment to measure out 3 meters? I know one of the main responsibility of athletic therapists are to set up treatment rooms, especially when you're traveling with a team and away. So should that be a part of your processes now to, again, help to make things go smoother if you should have to perform this test? Again, one of the critiques here is that they don't tell you what a normal limit or what sort of time they should be doing, or how to interpret the times that you're going to get, whether they're good or bad, or what an expected normal time would be to complete this task. Additionally, again, this optional dual task is another thing that can be done after the timed tandem gait. And this is something where you're doing a tandem gait, but now you're counting backwards by 7 from 100. Personally, I think this is a little excessive. I don't really know the reasoning behind it. They don't describe why they did it other than to make it more challenging. So again, I don't really know the utility of this. But we'll talk about that. Hopefully it'll come up in discussion. I'm happy to hear your opinions on it. Moving on to the delayed recall. Again, similar process. I think, again, just a formatting change here, listing the words in a vertical fashion, providing you the ability to score them. Whereas before, you're like scrambling to write down the words that they're saying. You're flipping back to the other page to try to remember the words yourself. And it was always a little bit challenging, I found. So I find this formatting to be very welcoming. At the bottom of the page, there is a total cognitive composite score, which they identify help to improve retest reliability and reduce false positives. So moving on, we've kind of reached the final page where comparatively on the SCAT5, the summary was just at the bottom of that last page, whereas now it is a full page. And I think this is helpful to just sort of summarize everything, and also help with the transition of care, especially if you're administering a SCAT5 on an opposing, or sorry, SCAT6 on an opposing player, and they're going to then be going back to their home therapist, their home physician. And so having this summary page can be helpful to just go over everything that was done in one nice concise area. interestingly, the warning there at the sorry, just go back one more. The warning there at the bottom of the page, you can see in the SCAT5 was in red, saying that it's not a standalone test, whereas that note is just very much at the bottom of the SCAT6. And one of the things that they say in the SCAT6 is they say, remember, an athlete can score within normal limits on the SCAT6 and still have a concussion. But they don't identify what within normal limits is for a lot of these tests. I'll leave that out there for what it is. Moving through things. So in the SCAT5, they had all these pages talking about injury advice, concussion information, return to play, the instructions. This is no longer present. And so, I don't know why they removed it, but it's now in the consensus statement otherwise. So in the SCAT6, they initially proposed, in the consensus document, they initially proposed the changes to the SCAT5. They were voted on and they didn't reach consensus. So then they further voted on each subsequent individual subcomponent. So you can see, they reached consensus when it came to removing the 5-word list, as well as adding the dual tandem gait. They felt that they wanted to make the most people wanted to make it optional to add the VOMs, and a large portion disagreed, and none of them wanted to add the VOMs, and some of them they reached consensus that it should just be an option. So we've reached the end of the tail of the tape, and so in Rocky, he was was for sure the winner of that match. I think, as I go through this slide should probably have a question mark next to it, because I'm not sure that the SCAT6 is the champion that we were all hoping for. But I do think that there are a lot of great things about it and a lot of things that, could be improved. So just to summarize some of the changes that we've seen throughout it. So they've added a lot of inclusive language, which I think is great. The timing has been increased from 10 to 15 minutes. And they've added this on-field assessment flowchart, which was helpful. Additionally, they've also done moved the coordination and ocular motor screen to the on-field assessment. They removed the 5-word list with only the 10-word list. The months in reverse now need to be completed in less than 30 seconds. And they've added this time tandem gait and dual gait task. So like anything, like any document, there are strengths, as I mentioned, and there are areas of improvement. One of the biggest things for me is just the improved formatting and real ease of administration, much easier to follow. The observable signs are a little bit more detailed. They've done their best to limit or lower the ceiling effect to help with the reliability of it. They've certainly stressed the importance of the ocular motor symptoms early on. I think the summary page is great, and they've tried their best to influence sport organizations to allow adequate time for the administration of this tool. So for areas of improvement, I think with consensus statements, especially in a field like concussions, where there's a lot of research, but not a lot of good research, because it's just a challenging area. They need to provide a little bit more rationale for some of these changes, not just, hey, we're a group of people who are experts and we just decided on this because we decided on it. Prolonging the administration time, I think, can have some negative effects, because we're under pressure on the sideline to administer this, get them back in the game. The player wants to get back in the game. The coach wants the player back in the game. There's all these competing things. So, probably would have been better for them to shorten it, not elongate it. And so they've really tried to make it more challenging, but at what cost? So is there now an increased need for baseline testing? I understand them wanting to make it more challenging, but providing more guidance in terms of what an expected number of errors should be would be important. Interestingly, they didn't add the VOMs. I sort of understand why, because it does take some time to administer the VOMs. It is in the scope, which I think is probably where it's most valuable. And then again, I question the utility of the tandem and dual task gates as part of your assessment. So that's it. That is the tail of the tape and the comparison between the two of them. Thank you for your attention. My email was there on the previous slide. If you want to reach out, please feel free to do so. I'm happy to connect.
Okay, great. Thank you, Alex. That was great. I'm just gonna ask the OATA Secretariat to take a look for any questions for the Q&A now. Participants can raise your hand or write something in the chat. And then
Sarah and Dr. Alexander, we do have a question. Dan's asked, if we are working hockey, could we not do best barefoot and then with skates on?
Yeah, you could do it barefoot. I don't know the utility of, I think doing it on skates would be a little bit challenging. Personally, I have sometimes sort of deferred the best in a hockey situation, but I think, yeah, taking skates off is probably better. I think the unique balance challenges on skates, especially when you're doing it in a locker room, is a little bit difficult.
There's a question about the ocular therapy. You mentioned red flagged it, that it's come up now with the SCAT6, and the question is, what are you suggesting in terms of an on-site or an on-field test for that any ocular concussion?
Yeah, so if you go back, onto that on-field assessment, the ocular motor screen is the main thing that they recommend. So when you're on the field, they're recommending a finger to nose test. Interestingly, when I read through this now, they say doing a finger to nose test with eyes opened and closed. Personally, I've never done a finger to nose test with the athlete having their eyes closed. I don't see the utility of that. In the ocular motor screen, they're asking you to do extraocular movements without moving the head or neck, and seeing if there's any double vision, and then seeing if there's any nystagmus or other observable extraocular eye movement abnormality. So I think that's sort of your main sort of initial ocular motor screen. And then the other sort of, sort of vestibular and visual concussions and post-traumatic dysfunction in that respect is going to be done more in the office setting, not so much in that immediate sideline assessment.
There's another question. He's just saying, with Rowan's Law Day yesterday and a reminder about second impact syndrome, how do you think the new SCAT6 does in terms of capturing that concussion history that might impact decisions about when someone has to be taken out of the game?
That's a good question. I hadn't really thought about that when I was going through it, but I think, again, they certainly have maintained the importance of obtaining a thorough concussion history on that second page, where you're asking how many concussions they've been diagnosed with in the past, when their most recent one was, what their primary symptoms were. And I think, again, they're really stressing sort of observable signs to be important. And like anything, I think at this point, many of us know, and it's been, pretty common knowledge amongst sports medicine community, that if you're in any doubt, you sit them out, right? Like, I know it's usually can be a hard decision to make, but we know that the consequences of not doing that can be catastrophic. And so you just kind of, got to stick to your guns. And I think that if this does a good job at, looking at red flags and providing you with hard objective signs that can help to support your decision. You know, if you get questioned by a coach, you can say, hey, listen, like, you know, I saw this player stumble. This happened to me at a U of T football game a couple of weeks ago. There was a big hit. I turned away for 1 second. The player got up and I saw him stumble. Nobody else saw him stumble. And we pulled him right off the field, and he was out for the game. So it's just a matter of, you know, really using this as something that you can fall back on. So I think it does a good job there.
Well, that's a perfect segue, because the next question is from someone who was actually at the Saturday session with that OETA did with Heads Up Canada's network, Concussion network, sorry. And there was an issue about who has the authority. If in these volunteer situations where parents are now being empowered to make, you know, to observe and make decisions about who should come off, and the coaches, if there's an AT there, what's the pecking order? Because sometimes a trained eye sees, like yours did, and the others don't, and then nobody wants their child out of the game. So what do you think what part of the SCAT do they pull out in terms of making sure there's some priority to make sure the child is safe?
Right. Well, I mean, I think that it's right in that first sentence. What is this? What is the SCAT6? It's an evaluation concussion tool designed for use by healthcare professionals, and the healthcare professional, I think, has the authority there. And it says, you know, in that first page, if you are not a healthcare professional, please use the concussion recognition tool. So, you know, I think it depends on your role. Like, are you there as you're an AT, you're a parent who happens to be an AT and you're at your child's game, or are you the athletic therapist that you know, has the responsibility to these athletes? And I think it's clear that if you're in that role, then you supersede, you know, a parent or a coach 100%. Like, I think without reservation. That's my own personal opinion. They don't say that, but I think that's my interpretation of this document.
And finally, there is one last question, Sarah. It's just if it's not a diagnostic tool, right, and it is for helping, there's some controversy among some of the members here in terms of the toolkit, right? And someone's just asking, what do you think in terms of the ranking of this? If it's not a diagnostic tool and it goes into a toolkit, and you agree baseline testing's not evidence-based at this point, how do you rank or weight the new SCAT6 compared to the Canadian concussion guidelines or the living concussion guidelines?
Yeah, I think, again, it's a tool. Ultimately, concussion is a clinical diagnosis, so we're never going to have a full consensus. You know, part of that is going to be, you know, if it's your team and you know your athletes well, then you have to go on your clinical judgment, and you say, okay, well, this player does not seem to be at his baseline. I think that, again, the observable signs are something that are very easy, and something that can not something that easy, but something objective that you can fall back on. And you really just want to kind of take the entire picture. You have to use your own, you know, clinical experience in terms of the concussions that you've seen in the past. You know, does this seem like a concussion? Is the athlete responding more slowly than normal? And again, I think that this is where the SCAT6 does fall a little bit short in terms of providing us with the guidance of what normal limits are and what an expected number of errors are to be on the variety of different steps. So again, it's never an easy decision. You know, personally, I think you always err. I've always erred on the side of caution. And looking at the whole thing, you know, looking at the impact of the hit that they took. Was it like a small fall, or, you know, was it an elbow to a chest and they just sort of fell backwards? You know, do you have video review that you can look at? You know, all these different sort of factors that come into play. one of the other things that you want to, that they don't do in the SCAT6, but, for example, is used in the MLS and in FIFA and in soccer, is that there is an exertional component before the return to play. So you're completing your on-field assessment, you're asking the patient about questions, and then they have to run up and down the field a few times to see if they're feeling okay. And if they clear that, then you go. And again, a concussion is an evolving tool. So that's the other thing, right? You may send them out there, and then, 2 minutes later, well, they're not really following up with the play. They're going the wrong way, they're stumbling. Then again, you can pull them out. So it's tricky for sure, but you just got to kind of use, all the tools that are available to you to help you make the best decision.
Okay. I believe that I think we're heading in the direction that is the end of the questions. Some really great ones. Really appreciate everybody taking part and participating. I want to thank you, Dr. Francella, for this wonderful presentation, for joining us this evening, putting all this effort out, and really trying to make things as clear and understandable as possible. And this concludes our final webinar of the 2023 Concussion Week series. So thank you again. Really appreciate everybody's time. Thanks for coming out. And everyone have a great night.